I am Andy Allison, a member of the board of the Prevention of Blindness Society. I'm also an ophthalmologist in this area. I specialize in glaucoma, and I kind of head the glaucoma screening part of the Prevention of Blindness Society, as well as the Glaucoma Task Force. And I've been teaching at the Washington Hospital Center Georgetown program in glaucoma for too many years. And one of the students that I had the pleasure of interacting with is Stro Ashburn, who is here tonight to talk about Glaucoma 101. He is a local member who grew up in DC, went to school at Landon, and trained at the Georgetown Washington Hospital Center program, and has joined his father in practice here in Washington after going to University of Virginia in Charlottesville for his glaucoma fellowship. And he's going to answer your questions and give you some ideas about what glaucoma is and how you can make sure, if you have it, that you get it treated and to be safe with your eyesight. So I'm going to turn it over to Stro and have a great evening, and I'm sure you'll enjoy his discussion.
All right, thank you, Dr. Adelson, for that wonderful introduction. I've never been introed before, so thank you very much. As Dr. Adelson mentioned, I am Stro Ashburn. I'm a local ophthalmologist here in DC. I'm with Eye Associates of Washington, DC. Also, as you mentioned, I am a glaucoma specialist, joining my father, who's also a glaucoma specialist, come from a long line. And so I was asked to speak about, kind of a Glaucoma 101, just to introduce, what is glaucoma, how is it treated, what we can do about it, that sort of thing. So without further ado, everyone see the PowerPoint here? Okay, great. So, all right, let's see if it'll work. Okay. So what is glaucoma? Well, it is the second leading cause of blindness worldwide, behind only cataracts, believe it or not. It is the leading cause of irreversible blindness in African Americans here in the United States. And I like to call it the silent stealer of sight, since it is largely or almost completely asymptomatic in the early stages of the disease. And when we lose vision from glaucoma, we can't get it back. It's irreversible vision loss. Okay, so glaucoma is a disease of the optic nerve. It's typically associated, or it is associated with, a typical optic nerve appearance, which we call cupping. So if you see in this picture here on the right, that is a glaucomatous optic nerve. The optic nerve kind of looks like a donut, and the larger the donut hole is, the more it looks like glaucoma, basically. So this orange layer of tissue out here on the outside is healthy rim tissue. Here in a normal optic nerve, it's much thicker. In a glaucomatous optic nerve, it's much thinner. So that's what we're looking at when we are investigating for glaucoma, and what we mean when we say cupping. It's also, now you can have cupping of the optic nerve but not have glaucoma. Some people are just born like that. So you also have to have a typical visual field deficit, and something like we see here on this Humphrey visual field, which is performed at your eye doctor's office. And it measures specifically the visual field defect, and it starts in periphery and then kind of closes in centrally. And then lastly, glaucoma is usually associated with high eye pressure, although not always. So speaking of eye pressure, where does it come from? Well, normal pressure is between 10 and 22. Now that can vary from person to person, depending on thickness of their cornea and some other factors. But generally, that's a good rule of thumb. 10 to 22 is normal. Now, pressure in the eye comes from, well, the aqueous humor, which is secreted by this ciliary body right here, which is behind the iris. The fluid flows through the pupil and then around and then into what's called the anterior chamber, which is in between the cornea here and the iris here. And then the fluid exits through the drain of the eye, which is called the trabecular meshwork, or the angle where the cornea meets the iris. Now that can either be open or closed. We'll talk about that later. And bottom line with this is increased pressure leads to optic nerve damage. That's a little oversimplification, but for our purposes, that'll suffice. So there are two main types of glaucoma. There's open angle, which is the most common. It happens very gradually over a period of many years and decades. And unfortunately, it's asymptomatic. So a lot of people that, or most people that have early forms of the disease will not know they have it. It doesn't cause any pain. It doesn't cause any blurry vision. It doesn't cause any eye redness, anything like that. Now, narrow angle glaucoma is less common, at least in this country, and it can be symptomatic in what's called an angle closure attack. You will have sudden blurry vision, severe eye pain, so much to the point where someone can be throwing up from the pain. You'll have a very red eye, and you'll see a lot of halos and rainbows around lights. Now, if you have any of these symptoms, or all of them, go see either your eye doctor right away or to the emergency room, because this is a medical emergency that can be treated. But if it's not, it can lead to permanent vision loss and even blindness. So that is something that's important to know. Okay, so who is at risk for glaucoma? There's a lot of risk factors, but generally the older you get, the more at risk for glaucoma you become, especially once you hit the age of 40. If you have family history, of course, there are some genetic components to this disease. If you're of African, Asian, or Hispanic descent, you're more at risk. Of course, if you have high eye pressure, you're more at risk for glaucoma. Now, if you're farsighted, you're more at risk for the angle closure or the narrow angle type. If you're nearsighted, you can be more at risk for the open angle type. If you've had a history of eye trauma or injury to the eye, you're at risk for certain types of glaucoma. If you've been on steroids long-term or had short-term but high-dose steroids, that can raise your pressure, and that can give you glaucoma. And then there are some medical problems that are associated with glaucoma as well. High blood pressure, diabetes, migraines can maybe put you more at risk. Okay, so how do we diagnose as doctors? How do we diagnose glaucoma? Well, it's largely, or it is, a clinical diagnosis. There's no blood work or laboratory test that we can do that say, yes, you have glaucoma. So the best way to do it is with a complete eye exam. So we'll measure, well, your vision, of course, and then eye pressure, which is seen here in the photo. We'll do a visual field, either confrontation, holding fingers up, but a more precise way to do it is with an automated perimetry, like a Humphrey visual field, where you stick your head in a box, essentially, look straight ahead, look at a light, and then there will be flashing lights all around. Some of you may be familiar with this test. Try not to fall asleep during it. And then next, we'll look at the angle or the drain of the eye, see if it's open or closed or narrow. We'll, of course, look at the optic nerve to see if it has any of that typical cupping. We'll measure cornea thickness. The thicker your cornea is, the more protective that is against glaucoma. If you have thin corneas, you're a little more at risk for multiple reasons. And then, of course, we'll do some imaging as well. Take photos of the optic nerve, something called OCT, where we can measure the thickness of the optic nerve, and that's really helpful both in diagnosis and in following progression or stability of the disease. So it's determined, you've determined, or you think you may be at risk for glaucoma. What should you do? Well, first thing, of course, a baseline exam, especially if you're over 40. And this can include the visual field and the optic nerve imaging that I just mentioned. And then it is important to follow up with annual exams, especially if you are a glaucoma suspect or if you're at higher risk for glaucoma. just because you don't have it when you're 50 or 60 doesn't mean you won't develop it down the line. Okay, so say you're not just at risk for glaucoma, but you have been diagnosed with glaucoma. What do you need to know? Well, the first thing to know is that there is no cure, unfortunately, for this disease. Again, once you have nerve damage and once you lose vision from glaucoma, we cannot restore it. So the goal of treatment is preventing further or any optic nerve damage and vision loss. Now, there are a lot of factors that go into nerve damage and vision loss, but the only one that we can modify at this point is lowering the IOP or intraocular pressure. And this includes even if your IOP is already normal. Now that can be normal on drops that you started out high and now it's in the quote unquote normal range, or, you know, some people come present to us with a pressure of 16, but they have cupping and they have visual field defects. So, and they haven't had any history of high eye pressure in the past. That's called normal tension or normal low pressure, low tension glaucoma. And still the treatment is just to lower it. So how do we lower pressure? So one of three ways: with a laser, with a medication, or with surgery. Now, I put it in this order deliberately, putting laser first. You know, previously, you know, years past, a lot of people always start with medication no matter what to lower the eye pressure. But nowadays, there's a lot of evidence that shows that starting with a laser, and I'll go over those in a second, as a first-line treatment, either works just as well or even better than starting with medication. But bottom line is, if you know we've kind of exhausted the laser and medication routes, then surgery is generally the third step out of those three. All right, so talking a little more in depth about lasers. So there's several different lasers that we have at our disposal for glaucoma treatment. So in narrow angle glaucoma, the standard of treatment really is peripheral iridotomy, which allows fluid to, you can see here in this picture on the top part of the screen, that little hole to the left of the iris is the iridotomy, and that allows fluid to escape from behind the iris, which backs it off, which can open the angle and then allow the drain to function again. And that in some cases can be curative. I know I said there's no cure, but in this case, it can lower the pressure, sometimes permanently. And so someone needs to never be on drops anymore. Now, that doesn't mean you can't stop going to your doctor. You still need to go and make sure that the pressure doesn't go back up, or that the angle doesn't close, or that the iridotomy doesn't close. But that is pretty much the standard of treatment, of care for narrow angle. Now, say you have open angle, open angle glaucoma, there are still good options for you for laser treatment in the form of laser trabeculoplasty. And one of the older ways of doing this is with an argon laser. It's just the type of laser it is. And that would actually burn holes in what's called the trabecular meshwork in the drain of the eye here, which would kind of open up the drain a little bit and allow for more drainage. Now, unfortunately, that's, you know, once you burn holes in the eye, you can't really, and you go all 100 or 360 degrees around, you can't really do that again. So it's not very repeatable. It can lead to scarring. It can lead to a lot of inflammation at the time of the procedure with pressure spikes. So, you know, it's still used today, and it works well, but in certain cases, but it's generally been dropped in favor of selective laser trabeculoplasty, which is what this is pretty much displaying here in the illustration. A selective laser trabeculoplasty is used with a different type of laser that it doesn't burn holes or, you know, make any tissue damage inside the eye. It just excites the drain and get it working again and get it flowing again. And it works, you know, 24 hours a day, 7 days a week. It can usually lasts for about 3 to 5 years, after which it can be repeated. So it's an excellent form of treatment. It's an in-office procedure. It takes about 5 minutes to do. You drive yourself there and back. You know, sometimes your eye can be a little red or irritated for a couple hours afterwards, but it doesn't really have any short or long-term side effects. So it's a very safe and effective procedure that can just be done in office. So, and then the last type of laser I'll mention is something called cyclophotocoagulation, which is typically done further down the road. It can be considered part of our surgical armamentarium, but I'll mention it here with the lasers. And we use the laser to apply it here to the ciliary body. The ciliary body is the part of the eye that, again, produces the fluid. So by applying laser to it, our goal is to kind of decrease the amount of fluid that's produced by damaging those cells. So we're kind of turning down the faucet, if you can think of it like that. Now, there's also evidence that it may open up the wall of the eye a little bit, make it a little more leaky, so to speak, and increase outflow that way. So it possibly has multiple mechanisms of action that we're still finding out about right now. But that's a very good procedure. It's non-invasive. It can be painful, so that's why we do it in the operating room under anesthesia, but there's no restrictions before or after, and it can be very effective and, again, last for a very long time. So I've already mentioned some of this, but the advantages of the laser, it's a one-time treatment that lasts for years. It can be repeated. It is covered by insurance as well, so you don't get huge copays with it. Again, there's very few or rare adverse effects. Maybe some blurry vision for a few hours, red eye, irritation, but that's generally limited and very mild. And something like selective laser trabeculoplasty usually works about as well as one medication. So that's why it's an excellent first-line treatment, and I think it should be offered more. Now, you know, not every patient is going to want to jump straight to laser. And that's fine. But I think people's reluctance to use it is because we just don't offer it as much or don't promote it as much, but it is an excellent procedure to do. All right, so say you don't want to do the laser, or the laser, you know, got the pressure down a little bit, but, you know, not enough. Say you started out at 30 and now you're at 22, but we wanted in the teens. What else can we do? Well, that's when we would go to glaucoma medications, which is mostly in the form of drops. If anyone listening has glaucoma or has a family member with glaucoma or knows someone with glaucoma, I'm sure they're very familiar with their drops. Maybe not know the name, but certainly know the color of the bottle. And there's many different types of glaucoma medications out there, including those that decrease aqueous production. So like I said, kind of turn down the faucet. So that can be your beta blockers like timolol, your carbonic anhydrase inhibitors like dorzolamide, and your alpha agonists like bromonidine. That's yellow bottle, orange bottle, purple bottle. And then there are others that increase uveous scleral outflow. So that's just a fancy way of saying making the eye more leaky. So it increases fluid outflow through the wall of the eye itself, which is a natural form of outflow for the eye that we don't really think of typically. But this prostaglandin analogs like latanoprost or Lumigan or Travatan enhance that pathway. There's also something like Latisse that, if people are familiar with the drop that makes your eyelashes grow longer, that's what this is. It's a glaucoma medication, which we'll talk more about in a second. And then there are those that also increase what we call trabecular outflow, or that's outflow through the drain of the eye, through the angle. And these include your newer Rho kinase inhibitors, something like Ropressa, Notarsadil, or miotics, of which pilocarpine is the most well known, and that has been around forever, for decades. Something my dad was using when he was a resident in the 70s, that's actually being marketed now as I don't know if anyone's seen commercials for Vuity, but that's pilocarpine, and it constricts your pupil and allows you to read a little bit better. And they're always, these drug companies are always finding new ways to market things. Okay, so what are the downsides of medications? We all know they work, but what are the downsides? Okay, so you have to use them at least once a day. Most, the prostaglandins are, once a day, but pretty much everything else is multiple times a day, 2, 3, even 4 times a day in the case of pilocarpine. And, getting the drops in can be difficult. I mean, this poor guy up here forgot to take the top off. So it's, a lot of our older patients too, if they have arthritis or, a tremor for whatever reason, can be really tough to get those drops in. They do make some drop assist devices that you can get on Amazon if you just search for them, but it can still be pretty tough to get them in. And every drop has a side effect. There's no perfect drop out there. Even the most benign ones can still cause irritation when you put them in. Latanoprost and the other prostaglandins have sometimes desirable side effects, like I said, making your eyelashes grow, but they can also make your irises darker. If you have hazel eyes and you like your eye color, that'll get darker, which a lot of people don't like. It can give you dark pigmentation around your eye, and it can cause something called periorbital fat atrophy, where the fat pads around the eye, which normally provide a nice full look of the eye, those start to atrophy, and so your eyes appear very sunken in, which can make you look a lot older. So that's that comes after decades of use, but it is something to keep in mind. The beta blockers can lower your heart rate, make you short of breath. The carbonic anhydrase inhibitors and alpha agonists you can develop allergies to them. So, like I said, there's no perfect drop out there. And then lastly, of course, some of these are very expensive. So, the older ones, that generics are out, you can get them for $4 on the Walmart plan, but, it's not nothing. And, if you're on them for months, decades, that adds up. And then some of these are, especially the newer ones that insurance is reluctant to cover, can be, $200 a month or so. So the costs do add up. So, medications, they're great, but they also have some downsides. So because of these downsides, we are looking into ways to, get around the dosing dilemma here. And so we're looking at extended duration options. Now, the only one that's approved right now in the United States is something called Durysta, which we see pictured here. That's injected into the front of the eye with a small needle. And it's this little white guy here that is a sustained release device that sits in the front of the eye. You don't feel it or see it or anything like that. And it slowly, over the course of several months, releases bimatoprost, which is a prostaglandin analog. And it's been shown to be effective, and sometimes for up to a year with one application. Problem is, it's only approved for one application right now. So after it wears off, you have to go back to drops or laser or whatever. But it can be a good bridge either to surgery or to just give people a break from drops for a few months. Other than that, there are some others in development, like external inserts, which consists of like a contact lens or a ring, a drug-eluting ring that can be placed in the eye. Punctal plugs are plugs that go in the tear duct here towards your nose. And they, again, kind of with the same deal as as Durysta, it slowly releases medication over a certain amount of time. But those are still in the investigational phase right now, and there's nothing approved here in the United States yet. But hopefully in the next few years, we'll have those options to offer to patients. Okay, so say laser didn't work, medications don't work, or you're undergoing cataract surgery, so you're getting surgery anyway, so we might as well do cataract glaucoma surgery at the same time. What can we do? So there are right now many different surgeries and procedures available to us. It's really kind of exploded in the last decade or so, just as we've had more devices and techniques available for us in the what we call the minimally invasive glaucoma surgery, or MIGS space. And typically these involve what we call angle surgery. So basically our approach to this is to either stent or clean out the drain of the eye, the angle, in hopes of restoring your natural flow through there. And this can be easily done at the same time as cataract surgery. Cataract surgery itself is actually has been shown to be a good glaucoma procedure as well. It can give you sustained pressure drops, only maybe of a couple points or two, but that can be important, or is important. But yeah, angle surgery, so something like the KDB or Cahook dual blade, GAT, which is gonioscopy assisted transluminal trabeculectomy, iStent, Hydrus, Omni. I mean, there's a lot of different ways, but basically they all do similar things in that they stent the drain open or clear it out, so in an effort to restore flow. Now, sometimes the obstruction of flow, outflow, is past the drain of the eye, the angle, or the angle is completely closed off and we can't open it up again. So what do we do then? Then that's when we will consider something called a filtering procedure, where we bypass the drain completely. Kind of the granddaddy of them all is something called a trabeculectomy. That's been around again for many years, decades. And when it works great, but it can have some side effects. So what we do with there, we basically just make a partial thickness hole in the eye and hope it doesn't heal up all the way. So the fluid from the front of the eye filters into what's called a bleb here, which is kind of like a blister on the surface of the eye. And that's very effective in getting the pressure down to single digits a lot of the time, and keeping it there over the course of many years. Now, there are risks. Well, I'll go over those in a second. If we don't think a trab is a great idea, or not indicated for the patient, there's also some glaucoma drainage devices or tubes that we can insert in the eye. They kind of, this middle picture here illustrates that. Almost looks like a computer mouse. So you have the reservoir up here in the tube that goes into the front of the eye that drains fluid that way in a controlled manner, so that you can avoid the pressure going too low, which can sometimes happen with the trab. It is a little more contained. You have a little less chance of bad side effects and scarring with the tube. And then there's also some minimally invasive filtering procedures, namely the Zen, which is available here in the United States. And that's a much smaller tube without a reservoir that is a very minimally invasive surgery, sometimes just consisting of a needle stick, that can work very well to lower the pressure. Now, the problem with that is that, it's still relatively new. We don't know the long-term results always, and it does show a little higher scarring rate of the others, so it has a higher failure rate. So that's a problem with the minimally invasive versus maximally invasive, I suppose. You give up some efficacy in favor of safety, because there are a lot of risks with glaucoma surgery. With a trab, you're always worried about infection, for the lifetime of that patient. Really, this is something called blebitis, where you get infection in the bleb, and that can lead to infection inside the eye, which can lead to blindness, which isn't good. So that has to be treated right away. A lot of times pressure can go too low, which can really affect your vision. With the tubes, you can get damage to other parts of the eye. You can see here the tube is a little too close to the cornea, which is causing some haze over the top of the tube, which can cause some decreased vision. Also, going back to this other slide, you see the reservoir of the tube is pretty far back on the surface of the eye, and then we get into the realm of the extraocular muscles. And if we interfere with those, it can cause double vision. So that's not great. And then like I said, these are probably the surgeries that we know will last the longest, but there's still, basically a 50% chance at 5 years that this surgery, no matter what we do, will have failed, and you'll either need more surgery or be back on drops or something like that. So we've come a long way with glaucoma surgeries, and we have excellent techniques, and when they work very well. But they can be a little messy sometimes. So that's what makes glaucoma so much fun, specifically surgery. But if the alternative is going blind, then that's a risk that we are certainly willing to take. And there are some excellent surgeons in the area that have a lot of experience with this. So I don't want to scare anybody off either. Okay, so going back to the original question. So I have glaucoma or at risk for glaucoma. What do I actually do? Okay, so most important thing, see your doctor, either for a baseline exam or go back to, a doctor you've been seeing for a long time. You'll likely be seeing them multiple times a year, especially if you have glaucoma. You'll be seeing them at least twice a year, likely more, just to make sure that the eye pressure is good, and to do testing every year to make sure that we're not progressing. Even if the pressure is where we want it to be, sometimes we're wrong at where we want it to be. So it's important to still get to still see your doctor, still get all the testing done, the visual fields, the optic nerve testing done at least once a year for all those, to know that we're on the right track. Once you see your doctor and speak with them, it is also important to pick a treatment plan, whether that's laser, drops, or surgery, and stick to it. So if you get the laser, show up for your appointment, get the laser done, and don't just think because you've gotten the laser you're cured. You still need to go back and see your doctor again, probably multiple times a year, even if your pressure's good, because it can basically wear off. Like I said, it usually lasts for 3 to 5 years, but it can wear off at any time. If you're on medications, take them every day, take them as directed, get your refills. Don't skip a day, even a day, if you have bad glaucoma, even a day of high eye pressure can cause nerve cells to die off there. And if you do all these things, I can almost guarantee you that you will not go blind from glaucoma. The vast majority of people that do go blind from glaucoma are people that present to us too late in the disease, or people that are lost to follow-up for whatever reason. It can be very legitimate, but I can think of a few patients just off the top of my head, especially during COVID, unfortunately, where we were under great control, and then just COVID, they weren't able to come in and see us. And then they come in a year or two later, their pressures are 40, and they've lost a lot of vision. So even during global pandemics, we want to see you. We want to make sure that we're following the treatment plan, and you're not losing any vision. If you do all these things, you will not go blind from glaucoma. On that note, so there are a lot of good resources out there. Dr. Google has a lot of things to say. Specifically, I like to direct people towards the American Academy of Ophthalmology, or AAO. They have excellent patient education in the form of brochures, videos, things like that. So you can go to their website there. Also, the American Glaucoma Society, which is our subspecialty society, has a lot of good education as well. So those are 2 resources that I would recommend. You be careful where you go to on the internet, of course, but these are 2 sources that are good. All right. On that note, thank you very much. And I will take any questions that anybody would have.
All right, Dr. Ashburn, thank you so much.
You're welcome.
That was really great. And just a little plug about these education places. That is a really great reference for anyone to check out. I use that a lot as well to help inform people as well. So that's a really, really great resource. I have a couple questions in chat box. I'm going to do it just in the order they came up, Dr. Ashburn. So
Okay.
That's the rhyme and reason that I'm doing it by. First is, what regimen does a patient have to maintain to prevent glaucoma from getting progressively worse?
So that really depends on the patient. So if it's someone that comes to me and they have a family history and their pressures are borderline, but their optic nerve is healthy, then I'll say, generally, okay, follow up once a year. Now, if on the other end of the spectrum, if someone has severe disease, their pressures are, kind of, again, borderline, but if they're at their target pressure, which if they have severe disease will probably be somewhere in the low teens. At that point, we need to see, for my severe disease patients, it's usually around every 3 months or so. So about 4 times a year. But then, if we do an intervention, change medications, do a laser, do surgery, then it's going to be more frequent than that to make sure that the pressures are where we want them to be. But yeah, so basically, the more severe disease you have, the more frequent you need to come in. And usually it's about 4 times a year for my severe glaucoma patients.
Great. Another question we got was, we talked about eye pressure a lot. What is normal tension glaucoma?
So normal tension glaucoma is glaucoma that is associated with a normal pressure. So, someone comes in and their pressure is 16, but they have optic nerve damage and that visual field loss. Now, we have to take a very careful history to make sure that, they don't have any evidence of high eye pressure in the past, or they haven't had any, injuries that can mimic this, or they don't have any certain types of infection or things like that. But, all that being normal, there are still some people that have glaucoma even at normal pressure. So as I mentioned in the talk, the treatment of that is still to get the pressure lower. So say you come in with a pressure of 16, let's try to get the pressure at 12 or below. Now, there are some studies that are out there that have shown that even if we get the pressure down where we want it, say 12 or below, you can still have progression. In fact, like 30% of patients still progress at those even very, very low pressures. So that just goes to show that there are a lot of other things that go into nerve damage in some patients besides the pressure. Unfortunately, there's nothing else we can do besides lower the pressure at this point. There are a lot of studies out there that are looking at something called neuroprotection in order to make the nerve more resilient to those pressures, and even neuroregeneration or gene therapy that could theoretically help, but we're not quite there yet. But that's what normal tension glaucoma is.
Thank you. Are you familiar with microinvasive glaucoma surgery?
So minimally invasive, microinvasive are kind of similar. It's kind of marketing in the terms of some of the other devices that are out there. And there are some devices that are very, very, very small, like your iStents, for example, are smaller than the font on a penny, they like to say. And so I'm familiar with a lot of those. I'm not sure which surgery the question is specifically referring to, but there are a lot out there that kind of market themselves as microinvasive, as a more minimally invasive. But again, this is a kind of area of glaucoma surgery that's really kind of exploded over the last decade, because there's a big demand and need for it. We don't always want to jump to the big guns of the trabs and tubes. If someone has, mild to moderate glaucoma is well controlled, we don't want to necessarily risk those problems that I mentioned by doing one of those bigger surgeries. So the micro or minimally invasive surgeries can be very helpful for patients in terms of getting them off of drops, basically.
Okay, thank you.
Mhm.
Next question, this is about a medication. Can prednisolone acetate ophthalmic suspension cause skin discoloration?
So that's a steroid, and steroids can cause some hypopigmentation or whitening of the skin. Generally, that's more in the form of like an injection of the steroid. Usually, if you're just on drops, it's not going to do something like that. The main glaucoma medication or eye drop that is known to cause discoloration of the eyelid skin, the irises, or the prostaglandins, like I mentioned, like latanoprost or Lumigan or Travatan.
Here's an interesting question, and it kind of brings up a larger topic. This person has wet AMD and they get shots monthly. They're also at risk for glaucoma. So would laser be available to them should they develop glaucoma? And then I have a follow-up for that, but I'll let you answer.
Yes, that is a great option for patients that are getting injections and don't necessarily want to be putting other stuff in their eye all the time. The laser is very safe and can be done. In fact, I did a laser on just the same type of patient a couple weeks ago, the day before he got a laser. So, it's not invasive at all. You're not making any incisions or anything like that. So there's no risk of infection. So you can certainly get the laser done at the same time, or around when you're getting injections for wet AMD.
Great. And then the follow-up question is kind of about the process for people that have multiple eye conditions. So we have all the time people that have AMD or diabetic retinopathy and glaucoma. How does the decisions get made about which things to prioritize, and what would you recommend to patients about how they can go about keeping all of that stuff in order?
All right, so that's a very good question. Yeah, because we do have a lot of patients that that are fighting wars on multiple fronts, I like to say. So and the priority is depending on almost what's more acute at the moment. If your pressure's in the 50s from neovascular glaucoma from diabetes, you need to get the pressure down right away, and you can but a lot of that does go hand in hand with treating the retinopathy as well. In terms of prioritizing, I would just leave that up to your doctors. A lot of times those are judgment calls depending on the patient, and we're constantly talking to each other. It's a pretty tight-knit community here. There's not a lot of us compared to some of the other doctors around there. So where a lot of us are constantly chatting back and forth on the best way to prioritize a patient, whether or not they how often they need their pressure checked, how often they need their retina checked, and maybe get injections. When I get calls from retina surgeons a lot that they're seeing somebody and now they have again that neovascular glaucoma and we need to do something about it right away. So we take care of that. And it can be a lot to juggle, all the different appointments, all the different drops and medications that we can put you on. So making a chart, with all the drops that you're on, bringing your drops with you to your appointments, always going to your appointments so that, we can make sure that you're on everything we want you to be on. Even if like the charts go by color, besides the names, like I said, all the drop classes are distinguished by their distinct color caps. So if you just remember, hey, I take my blue top twice a day, I take my teal top at night, I take my yellow top in the morning, then that that can be a good way to do it. But just whatever works for you. You get a family member that can hold you, or a friend that can hold you accountable, that can help put the drops in if you need help doing that. Those are ways to kind of stay on the ball, so to speak.
Great. And speaking of drops, someone asked, why do drops require so many doses, and why some in the morning, some in the evening?
So, I mean, drops, like any medication, the pharmacology, you put it in and it has a great effect, and then it slowly wears off over time. Some that half-life is a lot shorter than others. So something like pilocarpine, it's 4 times a day dosing. Something like latanoprost, it's just once a day at night. Now, the reason we do the nighttime drops usually is because they can cause a little redness when you first put them in, more so than some of the other drops. And so by the time you wake up in the morning, the redness is usually better. But there's no medical reason why you can't really do those drops in the morning. Now, there are other drops like Timol, like a beta blocker, that beta blockers can decrease your heart rate. At nighttime, your heart rate, your blood pressure drops anyway. So if you have very severe glaucoma and we're worried about the optic nerve getting all the oxygen it needs from blood flow, you don't want your blood pressure to drop too low overnight. So that's why, for example, Timol or a beta blocker, we usually dose in the morning instead of at nighttime in those situations.
Gotcha. Okay. Thank you. Next question. And these have been great. This has been great, Dr. Ashburn. I mean, we're learning a lot.
Yeah.
Sometimes the questions you unearth more than the original talk.
Yeah.
So let's see. I have glaucoma and I've had great vision for years. They had cloudy retinitis. They were given steroids, took the pressure up to the mid-20s, a lot of vision loss. Now my eye pressure has returned to 9 in both eyes, but my vision has not improved. Can I hope for my vision to improve?
So, yeah, that's a tough situation. It can be more so from, well, depending on if the vision loss is from the retinitis and the retina problems versus the glaucoma, that may or may not be able to be improved. Now, pressure going in the 20s, it's not terrible if you were very well controlled previously and your vision was always good. Hopefully, if the retina guys can get the retina looking better, then your vision may return. But as I talked about before, if it is vision loss from glaucoma, unfortunately, that's irreversible. So in your situation, I'm hoping that it's a retina issue and it's something that they can treat with injections or with surgery sometimes in order to clear things up for you to get you seeing better. But it really depends on the underlying cause.
Gotcha. Okay. I've unmuted somebody. Joe, do you have a question? You had your hand raised. Do you have a question?
Yes, I do. Sean, can you hear me?
Yep.
Great. So Doctor, I'm actually work with Sean as a low vision resource navigator. And some of our clients actually do have glaucoma. And one of the things that we try to do is assist individuals with glaucoma with any type of low vision support. So would something like magnification, contrast, lighting potentially assist someone experiencing glaucoma?
Yeah, all of those things are very helpful, especially in severe glaucoma. A lot of my patients that have a lot of vision loss, just, everything has a gray veil over it. So increased lighting and certainly increased contrast can be very, very helpful for these patients. Yeah, so thank you for helping out.
All right, we have time for about 2 more questions here. So next one, I have AMD, my pressure is 8. Is this low enough to be low pressure or normal pressure glaucoma, I guess, and should it be treated?
Yeah, so low pressure basically just means anything that's not high pressure. So that's certainly low enough to be considered low pressure glaucoma if you have glaucoma. Hopefully not. I'm sorry, macular degeneration. And hopefully you don't have glaucoma as well. But if your pressure is 8 and you're not on any medications or anything like that, and you are diagnosed with glaucoma, I would say yes, then that can be considered low pressure. And still, the goal would be to get it even lower, even though that can be very hard in that situation. But yeah, so basically, low tension glaucoma means anything where you don't have a documented pressure higher than 22.
Great. And then we get all the time people come and tell us they're glaucoma suspects. What does that mean?
So that means that you are at risk for glaucoma for any one of multiple reasons. That can be from your optic nerve appearance, your family history, if you've had high eye pressure, and some cases your optic nerves can look very healthy, but they look asymmetric. So one nerve looks different than the other. But those are really the main things there that we're worried about. Family history, optic nerve appearance, or high eye pressure. Really, if I label someone a suspect, generally.
Okay. And then can diabetes impact the optic nerve and glaucoma?
It sure can. So the worst way that diabetes can cause glaucoma is when you get something called diabetic retinopathy that causes new blood vessels to grow in other parts of the eye. Sometimes they grow over the drain of the eye, which can close it off permanently, which makes the pressure go up. And the only treatment for that is the tube that I mentioned earlier. But it can be very refractive even to that surgery, and that's a very hard thing to treat. And a lot of those patients end up blind, unfortunately. Now there are other ways that it can affect the optic nerve, but like with optic nerve swelling and things like that. But the neovascular glaucoma is the thing we worry most about with diabetes and glaucoma.
Okay. All right, this will be the last question for you, and this is looking towards the future. What future treatments or therapies are interesting or exciting to you?
So a lot of the new drug delivery devices are pretty exciting. I mean, if we can do those injections inside the eye more than once, that would be nice. If they're contact lenses that work very well, and really, so that's exciting. Really, the studies that are out there that are looking at the neuroprotection, ways to help protect the nerve from glaucoma loss, with medications or gene therapy or even stem cell therapy. That's very exciting. I mean, the holy grail is being able to reverse vision loss, and there have been some very early studies that show that may be possible. So that's regenerate optic nerve tissue. So that would be amazing if we could figure out a way to do that. And then there's always more surgical techniques and devices coming down the road that purport to be less invasive or safer, but just as effective as some of the other surgeries like a trabber tube that's out there. So it's just nice to have more tools. We certainly have a lot more tools than we did when, for example, my dad started practicing. So it's I can't imagine practicing in that environment that he started in. So we're very lucky in this day and age, and we're only going to expand our capabilities there.
All right. Dr. Ashburn, thank you so much for joining us today. This was really, really great. I know I learned a lot, and there's a lot of really great questions. Thank you, everyone.
Yeah, my pleasure. Thank you, everybody, for your questions.